Good afternoon, everybody. My name is Ankit Twitch, and I represent JP Brothers. Welcome all to the inauguration of our first online interactive e-learning course, Cracking MRCOG. Since 1960s, JP Brothers is helping medical professionals with publishing, printing, and distribution services. With time, we have started progressively venturing into continuous medical education programs, or CMEs, to help doctors with their professional development. JP Brothers is one of Asia's biggest publishing houses, and for the first time, we are introducing our e-learning course to enable all MRCOG aspirants worldwide to crack their MRCOG exams in one go. Cracking MRCOG has been designed keeping in mind all the hurdles and obstacles candidates face while preparing the MRCOG exam. This course gives the candidates flexibility to study as per their time availability, flexibility, and convenience. We are offering more than 2,000 SBAs, videos, and lecture notes, picture banks, and resources for last-minute revision. Cracking MRCOG is truly a complete package to help you with your end-to-end MRCOG course requirements. Candidates who are unable to join the complete course can take our mock exams for MRCOG 1 as well as MRCOG 2 in coming January month. I'd like to wish all the best to all the medical professionals taking this upcoming MRCOG exam and course. I'd now like to introduce Dr. Richa, who will speak a few more lines on this subject area.
Thank you, Mr. Ankit. So good afternoon, everyone. Here we are at the official launch of Cracking MRCOG, an online interactive e-learning program for MRCOG aspirants. In this presentation, I shall be talking about various global career options which are available to doctors post-MBBS with special emphasis on MRCOG exam. I know this session is being attended by several doctors who are planning to give this exam in future, some of whom are already enrolled in the course. So I shall also be discussing some questions which have been previously asked in the MRCOG exam. If you have any questions during the presentation, please post your comments and I shall answer them. We shall also have a brief question answer session following the presentation where I shall answer your questions. Now, post-MBBS, the doctors are faced with a confusion that what should be their global career option. They are not sure about the various global career options which are available to them. Now, the next slide is showing the several global career options which are available to the doctors after MBBS. Slide is not complete. The previous slide. Question is complete. It cannot be seen.
You just continue.
So the various global career options which are available after MBBS, there are two types of exams which are available to the candidates after MBBS. One is the licensing exam and the other is the membership exam. Licensing exam, as the name suggests, enables the doctor to obtain license to be able to practice in the foreign country. It could be United States, it could be United Kingdom, or it could be Australia. For United States, the licensing exam is USMLE, or the United States Medical Licensing Exam. For United Kingdom, it is PLAB, which is Professional and Linguistic Assessment Board. For Australia, it is AMC, or Australian Medical Council. The main problem associated with these licensing exams is that the candidate has to enter the country at a trainee level. So even if you are MD in India, you have to start right from trainee level 1 in these foreign countries. Also, these exams are not very easy and it takes a long time to pass these exams. Plus, there may be difficulty with visa processing in case of United States, especially with the government changing. So the second option which is available to the doctors is the membership exams. The membership exams are via royal colleges, and these are in United Kingdom or UK. These exams could be MRCOG, which stands for Member of Royal College of Obstetricians and Gynecologists. It could be MRCP, or the Member of Royal College of Physicians. MRCS, which is Member of Royal College of Surgeons. FRCR, which is Fellow of Royal College of Radiology. FRCA, or the Fellow of Royal College of Anesthesia. MRCPCH, which is Member of Royal College of Pediatricians and Child Health, or MRCP Psychiatry. Now, the advantage which is associated with these membership exams is that this is an international degree, and this enables the doctors to practice worldwide. And also, when they enter these countries, they get consultant level posts with these exams. Now, in order to become obstetrician gynecologist in India, all of you know that this requires an MD or a DGO medical degree plus residency training. Now, in India, the super specialization in obstetrics and gynecology is not well developed. After residency, a physician may choose to do optional fellowship to super specialize in one of the following areas. The various super specializations available include maternal fetal medicine, reproductive endocrinology, urogynecology, and gynecological oncology. Now, the system of obstetrics and gynecological training in the UK. First, let's talk about some concepts. In UK, the healthcare system is operated by NHS, which is a publicly funded national healthcare system for England. It is the largest and oldest single-payer healthcare system in the world. Now, the maximum obstetric care in NHS is delivered by midwives and obstetricians. The private obstetric practice is very rare in UK, and it is mostly by consultant obstetricians with midwife support. Another concept regarding the training in obstetrics and gynecology is RCOG. RCOG stands for Royal College of Obstetricians and Gynecologists. This is a postgraduate institute for doctors specializing in obstetrics and gynecology that administers exams, approves hospital training programs, organizes scientific meetings and courses, and is responsible for education and standards of doctors. Another body which is there in UK is General Medical Council, or GMC. This is a body for registering doctors who want to practice medicine in UK. This helps in regulating the medical practice and ensuring good medical practice. Now, if we talk about MRCOG, this is an international degree which has worldwide recognition. This is an integral component of the UK training system in obstetrics and gynecology. And all the obstetrics and gynecology trainees in the UK, they have to clear this exam to be able to work as a consultant. This exam comprises of 3 parts, Part 1, Part 2, and Part 3. Part 1 MRCOG evaluates basic and clinical sciences relevant to the subject of obstetrics and gynecology, and the basic eligibility required to give the Part 1 MRCOG exam is MBBS. The Part 2 MRCOG exam is also a written exam to assess the application of knowledge in the field of obstetrics and gynecology, and the eligibility which is required for giving the Part 2 exam is 4 years of clinical experience in obstetrics and gynecology, which is recognized by RCOG. Out of these 4 years of experience, at least 2 years should be in the last 4 years. The third part of the exam is the Part 3 exam, which is a clinical skills exam, or the exam which gives OSCEs, and this assesses the candidate's ability to apply core clinical skills. Now, this picture shows the pattern of specialty training in obstetrics and gynecology in the UK. In the UK, they don't have an MD or an MS degree as we have in the Asian countries. Neither do they recognize our MD degree. So, in UK, in order to practice as a consultant in obstetrics and gynecology, you need to clear 3 parts of MRCOG and obtain an ST5 level of training. And this ST5, or the Specially Trainee 5, it corresponds to 5 years of core training in obstetrics and gynecology. Initially, you have foundation year 1 and foundation year 2, and this is equivalent to our internship program. Following this, the specialist training starts, and this corresponds to ST1 level, which is the specialist trainee 1, and this goes on to the ST5 level, which is the specialist trainee 5. Now, of these, the first 2 years, that is ST1 and ST2, it comprised the basic training in obstetrics and gynecology. The MRCOG Part 1 exam is usually attempted at ST2 level. For the overseas candidate, even though we just need a medical degree to be able to attempt the Part 1 exam, it is advisable that you have obtained some basic training in obstetrics and gynecology before you attempt the Part 1 exam. Then from ST3 to ST5, this corresponds to the intermediate level of training in the core curriculum. The MRCOG Part 2 and Part 3 exams are usually attempted when the candidate reaches the level of ST5. Clearing the second and third part of MRCOG exam marks the completion of core training, and then the advanced training begins. The advanced training corresponds to ST6 and ST7. At the end of ST7, the candidate is awarded the Certificate of Completion of Training, or the CCT. And following this, they can move towards independent practice as a consultant. Now we have discussed about MRCOG. Talking about the cracking MRCOG course, most of you already know about it. And for the candidates who are wishing to apply for this course or know more about the course, you are requested to kindly visit our website, which is www.crackingmrcog.com. And you can contact us. The email address, the telephone number, everything is given in the website. In case of any query, you can contact us at those details. Now, discussion related to some difficult exam questions which have been asked in the September 2017 MRCOG Part 1 exam. The first question is, in the normally arranged data dealing with BMI of women aged 25 to 40 years, mean BMI is 25% and the standard deviation is 5. What is the percentage of obese belonging to class 2 and class 3? The options are A, 2.5%, B, 5%, C, 16%, D, 32%, and E, 34%. The answer to this question is A, which is 2.5%, and the explanation is as follows. This slide is showing the classification of body mass index, which has been devised by WHO. Now we have to find the percentage of people which are in class 2 and class 3. If you see the class 2 obese people, the BMI is 35 to 39.9. So this is equal to 35 can be described as 25, which is the mean BMI, plus 2 standard deviation, which is 5. So 35 is equal to 25 plus 10. Similarly, the class 3 obese people, it can be described as 25, which is the mean BMI, plus 3 standard deviation, which is 5. So 25 plus 15, which is 40. So basically what we are required to do in this question is, we need to find out number of individuals which lie between mu plus 2 standard deviation and mu plus 3 standard deviation. Now you can see this is the normal Gaussian distribution curve. 99.74% of people would lie between mu minus 3 standard deviation and mu plus 3 standard deviation, as well as 95% of people would lie between mu minus 2 standard deviation and mu plus 2 standard deviation. So if we subtract these two values, that is 99.74 and 95, we get a value of 4.74. And if we divide this by 2, we get a value of 2.37, which is almost near to 2.5. Hence, the correct answer is 2.5%. Now, coming on the next question, there was a sudden deterioration of a woman following delivery who is now on 35% oxygen. Her arterial blood gases showed the following results. pH is 7.2, the partial oxygen saturation is 83.4, her partial carbon dioxide saturation is 8.4, base axis is minus 2.4, and bicarbonate level is 25. Now, what is the metabolic disorder in this particular scenario? The options which are given are respiratory acidosis, respiratory alkalosis, metabolic acidosis, metabolic alkalosis, and E is respiratory acidosis with metabolic compensation. The answer in this case is E, and the explanation is as follows. The normal pH in the human body, it ranges between 7.35 to 7.45. Therefore, a pH of 7.2 is suggestive of acidosis. Normal partial oxygen saturation ranges between 95 to 100%. In this case, the oxygen saturation is 83.4. So that means it is on the lower side. On the other hand, the normal carbon dioxide saturation should be less than 5%. And in this case, it is about 8.4. So it is obviously increased. So therefore, in this case, the condition appears to be respiratory acidosis because the respiratory cause appears to be responsible for causing the reduced pH. Now, if it would have been just respiratory acidosis, the bicarbonate levels would have been low. If you see in this case, the bicarbonate level is 25, and normal bicarbonate levels, they range between 22 to 28 milliequivalents per liter. Therefore, this implies that there has been metabolic compensation to bring the bicarbonate levels within the normal range. The base axis of minus 2.4 in this scenario refers to a base deficit of 2.4, which is likely in this case due to acidosis. Base deficit of 2.4 milliequivalents per liter implies that 2.4 milliequivalents per liter of base needs to be added to correct the pH. Then there's a third question which is related to interpretation of CTG graph. Now in this case, a midwife asks the obstetric registrar to review a primary gravida in labor who has progressed to 6 centimeters dilatation with an abnormal CTG. The CTG had been normal for up to 30 minutes previously. The registrar reviews the patient and confirms that the CTG has a baseline heart rate of 150 beats per minute with a baseline variability of 4 for the last 30 minutes. There were no accelerations, but variable decelerations were present. What would be the appropriate management with these CTG findings? The options are: this is a normal CTG and no intervention is required. B is, this is a suspicious CTG and requires continued obstetric review. C, this is a pathological CTG and fetal blood sampling is required. D, this is a pathological CTG and urgent delivery is required, or category 1 cesarean section. E, this is a suspicious CTG and fetal blood sampling is required. Now answer in this case is C. This is a pathological CTG and fetal blood sampling is required. Now this slide is showing the CTG trace of this patient. Now whenever we get a cardiotopographic trace, the 4 parameters which need to be assessed are: the first is the baseline heart rate, second is the baseline variability, third is the presence of decelerations, and fourth is the accelerations. The baseline heart rate normally varies between 110 to 160 beats per minute. Now in this question, the baseline heart rate is 150 beats per minute. So this means the baseline heart rate is fine in this case, and this is a reassuring feature. The second is the baseline variability, which in this question is 4 beats per minute for last 30 minutes. Now according to NICE guidelines, the baseline variability of less than 5 for 30 to 50 minutes is considered as non-reassuring. And in this case, the baseline variability is 4 for 30 minutes. So this becomes a non-reassuring feature. The third parameter to be considered is decelerations. We have been told in the question that there are presence of variable decelerations in this CTG. Now the features of non-reassuring variable decelerations are shown in this slide, and this includes variable decelerations with no concerning characteristics for 90 minutes or more, or variable decelerations with any concerning characteristic in up to 50% of contractions for 30 minutes or more, or variable decelerations with any concerning characteristic in over 50% of contractions for less than 30 minutes. Now, if we see the trace again, we'll discuss the concerning characteristic of a variable decelerations. Now, what are the concerning characteristic of variable decelerations is, if the variable deceleration lasts for more than 60 seconds, there is a reduced baseline variability within the deceleration, there's a failure to return to baseline, there's a biphasic or a W shape, and there is no shouldering. Now, these are the concerning characteristic of variable deceleration. If we see the cardiotocographic trace again, now if you observe in these and you look at the variable decelerations, you can see that towards the end of the trace, the variable decelerations are showing biphasic feature or a W shape. And there are plenty of variable decelerations towards the end which are showing a W shape. That means more than 50% of variable decelerations within 30 minutes period are showing a biphasic shape, or they are showing a concerning characteristic. So that means this becomes a non-reassuring feature of the CTG. So total we have out of four features which are to be considered, there are two non-reassuring features in this particular trace. Now, how do we classify the trace based on the features? If all the four features are normal for a cardiotocographic trace, then that is classified as normal. A cardiotocographic trace is classified as suspicious when one of the features are non-reassuring and the remainder of the features are reassuring. A trace is classified as pathological where two or more features are following in the non-reassuring category and one or more are in the abnormal category. Now, in this case, there were two features which were following in the non-reassuring category. So this trace becomes a pathological trace. Now, what is the management which is to be done in case of a pathological trace? The first line of management in case of a pathological trace is conservative management. This comprises of obtaining a review by an obstetrician and a senior midwife. Second is exclusion of acute events like cord prolapse, suspected placental abruption, or suspected uterine rupture. Third is correction of any underlying cause such as hypotension or uterine hyperstimulation. Fourth is counseling the woman and her birth companion about the situation and taking their preferences into account. If the cardiotocographic trace is still pathological, even after implementing these conservative measures, the following things need to be done. First is obtaining a further review by the obstetrician and a senior midwife. Second is the patient should be offered digital scalp stimulation and the outcome must be documented. If the cardiotocographic trace is still pathological after fetal scalp stimulation, fetal blood sampling must be considered. The baby's birth must be expedited, taking the women's preferences into the account. If you consider this question, then you will realize that, let's come back to the question. If you come back to the question which was originally asked, then you will realize that the options are, this is a normal CTG, no. Option A, B, and E can be ruled out because they are normal or suspicious CTG. Now, this is a pathological CTG, so we are left with option C and D. Now, she is already 6 centimeters dilated, so there is no need for a urgent category 1 cesarean section in this case. We can go for a fetal blood sampling, and in case the fetal blood sampling appears to be abnormal, we can go in for an instrumental delivery. So the option becomes C, which is a pathological CTG, and fetal blood sampling is required. Now, coming to the last question, which we'll be discussing in this session. This is a 55-year-old woman with absent periods for 2 years, has bilateral ovarian mass with solid areas on scan, ascites, and CA-125 levels of 100. Now, what is her RMI score? RMI stands for Risk of Malignancy Index, and this was a question asked in March 2017 exam. The options are A 900, B 600, C 700, D 450, and E 250. The answer in this case is A, or 900. Now let's discuss how we evaluate the risk of malignancy using risk of malignancy index. Now, evaluation of malignancy is based on combination of 3 pre-surgical features. This includes serum CA-125 levels, the menopausal status, which is denoted by the letter M, ultrasound score, which is denoted by the letter U. RMI is calculated using the formula U multiplied by M into CA-125 levels. Now, U is the ultrasound score. The ultrasound result is scored 1 for each of the following characteristics: multilocular cysts, solid areas, metastasis, ascites, and bilateral lesions. U is given 0 if the ultrasound score is 0. U is 1 for an ultrasound score of 1. And U is given a score of 3 for ultrasound score of 2 to 5. The menopausal status is scored as 1 in case of a premenopausal woman and 3 in case of a postmenopausal woman. The CA-125 levels are measured in terms of international unit per ml, and these levels can vary from 0 to 100 or even 1000 of units. So if we come back to the question, I'll tell you how we calculate RMI. Now in this case, the U, if we calculate U, this is a bilateral ovarian mass with solid areas and ascites. So U becomes, the ultrasound measurement, it becomes 3. And so U would be, when U would be 3, because when the features are between 2 to 5, U is 3. And the CA levels of 100, plus she is postmenopausal for last 2 years. So again, the M becomes 3. So 3 into 3 into 100, which is 900. So answer is A. Now, if anyone has any queries regarding the questions or regarding the course, you can contact us. These are the contact details which you can see on the slide. You can also visit our website www.crackingmrcog.com, and you can take the free trial. And if you are interested in taking the course, you can contact us. And last but not the least, thank you and good luck for your exam, and thank you very much for listening to this presentation. Now we shall take up the questions which you have put up. There's so many comments. Just give me a second. Let me scroll through it. From Pinky Chauhan. There's a question by Pinky Chauhan. Can a person in final year of internship and working as a house surgeon apply for MRCOG? Yes, definitely a person who is in final year of internship and working as a house surgeon can apply for Part 1, because once they obtain their degree or their medical registration certificate, they become eligible to give the Part 1 MRCOG exam. Dr. Ambika Kapoor, as I have passed MRCOG Part 1, can I go for Part 2 immediately? For Part 2, you require at least 4 years of clinical experience in obs and gynae. So if you already have experience, that much experience in obs and gynae, you can go in immediately. Otherwise, according to RCOG, once you've given Part 1 exam, you should give Part 2 exam within 7 years of giving the Part 1 exam. There's a question by Mr. Yogeshwar Pal. I have only 2 months in my hand to start my preparation. Will I be able to complete the course of 3 months duration? Okay, so this is about our Cracking MRCOG course, which is ideally for 3 months. But we have made it very flexible, and if somebody wants to complete it in 2 months, it is possible. So Yogesh, it is possible for you to complete this within 2 months. There's a question by Sharmila Pava. Will you come up with a course on MRCOG too soon? we are planning to launch the mock papers for MRCOG 2 in January. So we will have something for MRCOG Part 2 also. This is a similar question by Sunita Bisht. Are you offering courses for Part 2 MRCOG soon? I already answered it. Then Mr. Khalid is asking, I have completed Part 1 and Part 2 already. Do I need some compulsory training in UK to clear Part 3? There is no compulsory practice which is required in UK to clear Part 3. It can be, there are international centers for giving Part 3 exam. The exam is held in Singapore, Hong Kong and Delhi. So it can be attempted even if you don't have if you do not have any training in UK, then also you can give this exam. Very useful. Training or preparing good for overseas candidate. Question. That's not a question. Saurabh Kumar Jha, what are the highlighting features of your course? The main highlighting feature of our course is that it is a very flexible course, and the person who is pursuing this course can study as per their own time schedules and as per their own requirements. Whenever they have the time, they can take up this course. So that is the main highlighting feature. Plus, we are covering all the syllabus in form of 9 modules. And this is a one-stop gateway for MRCOG exam. Once you've taken this course, you don't have to consult other books. We are providing everything. We are providing the course manual, and we are also providing online practice session to practice the SBAs. We are providing lecture notes, videos, image-based questions, and resources for last-minute revision. Above all, we are also providing the final assessment or the mock exam, which you can take up in January. And that mock test can be taken as a standalone feature also. So if you have not bought the course, then also you can take up this mock exam. There's a comment by Sir, excellent information. Thank you so much, sir. Comment by There is a comment by Mr. Sukhdev Baluni, very useful training or preparing for MRCOG examination, good for overseas candidate. Thank you so much. There is a question by Anupam Singh. Can we have an access to this video later? Yes, you'll get an access to this video later. The sales people will arrange to send it across somehow. There's a question by Swati Mehra. How much flexible is the course for a practicing doctor? I've already answered it. It's a very flexible course because it will be giving you a facility to take online practice session. You can do it whenever you have time. So even if you are practicing in a hospital or you are on a night duty, whenever you get in time, you can squeeze in that time and you can practice the questions. There's a comment by Ritu Sharma. Dr. Ichha, congratulations. Thank you so much, Ritu. There's a question by Satish Tiwari. I'm planning to appear for January 2019 exam. When is it appropriate to buy the course? I would like to tell you that the validity of this course is 2 years. So once you buy this course, it'll remain valid for 2 years. And whenever you start using this course, the latest information which we have updated will be available to you. But once you activate the modules, each module, we have 9 modules in the course, and each module is valid for 10 days. So once the module is activated, After that, the course will expire. So it depends on you how you want to use it within the 2-year period. There's a question by Vandana Kumari. Is this course sufficient to prepare for MRCOG Part 1 exam, or would you recommend any other foreign book along with it? I have discussed this before also, that there's no need to read anything else. The course itself is sufficient because we are providing you with all kinds of resources. There's a question by Dheeraj Gambhir. I feel anatomy is most difficult subject. Can you please suggest me the best way to remember it? If there is some subject you are finding difficult, probably there'll be some subject you will be finding it simpler. So if you take up our course, maybe the one module which maybe it is that the biochemistry module, you'll find it simpler. So maybe you can do that in 2-3 days. And the time which remains from that module, you can devote it towards anatomy, because if you feel that is difficult, probably you'll need more time for that. There's a question by Ravinder Narayan. Medical system of UK is similar to India. No, it is not. We've discussed it in our presentation that the medical system is completely different in United Kingdom. The subject of obstetrics and gynecology remains same, but the medical system is different. There's a question by Anupam Singh. Is the course material given by you sufficient enough to get through, or do we need to go for more extensive coverage of the topics? If you feel at any point that you need to understand a particular concept more, you probably can refer to other books, because this book might not really help you in building up concepts. So if you want to build some concept in obstetrics or gynecology, you may have to refer to other books, but otherwise it's sufficient by itself. There's a question by Sudhir Panda. Do we need to go to UK for giving the Part 2 exam? No, you need not go to UK for giving the Part 2 exam, because if you have had 4 years of clinical training in India and that is recognized by RCOG, then you become eligible to give the Part 2 exam. There is a question by Arman. All it is there a time limit between passing the Part 1 and passing the Part 2 MRCOG? There is there is a time limit of 7 years, that once you have given your Part 1, you should attempt your Part 2 within 7 years. But there is no time limit on passing. You can pass it at any time, but you should, after giving Part 1 exam, you should at least give your Part 2 exam within 7 years. Harita, there's a question by Harita. After clearing MRCOG Part 1 and Part 2, can I get the degree of MRCOG 1, or I need to go in for Part 3 exam? Yes, definitely you need to go in for Part 3 exam, because now the RCOG has divided the Part 2 exam. Previously, there were only 2 parts of this exam, and now they have made the clinical examination as a separate part, and that is Part 3, and you have to very much clear it in order to get the MRCOG degree. There's a question by Swati Mehra. How many chances do we get to clear MRCOG Part 1 exam? If you're not planning to get yourself registered with the UK Medical Register, then you can give unlimited number of attempts at the Part 1 MRCOG exam. But in case you are planning to get yourself enrolled in the UK Medical Register, you can only give 6 attempts at the Part 1 exam. There's a question by Dr. Arun Bhatia. How long will the course be valid once bought? We've discussed this before, that the course will be valid for 2 years once it is bought, unless you activate the modules. There's a question by Tanya Banerjee. What is the difference between MRCOG and FRCOG? How these exams are different? There is no exam for FRCOG. FRCOG stands for Fellows of Royal College of Obstetrics and Gynecology. This is like a recognition of the senior post. People who have remained MRCOG for, I think, more than 12 years, they are eligible to be selected as fellows. And this is done by the RCOG committee itself. And this is like recognizing their services. So people who have done some achievement in the field of obs and gynae, they are the ones who usually get the FRCOG. So I think that's all. I can't see more questions. I cannot see any other questions. So there's a question by Anupam Singh. The time frame of 7 years starts after clearing part 1 or from the time the first attempt has been taken. No, it's. I think it starts after clearing the part 1. Because it says, the RCOG website says that you should attempt it within 7 years after you have given, last time you have given the part 1 exam. So obviously it means that after you've cleared the part 1 exam, the time starts from that. There's a question by Pinky Chauhan. Do I have to come to Delhi for the course? No, this is an online course, so you can be at any part of the world and you can take this course. You don't have to come to Delhi to take this course. There's a question by Misab Khan. Is MRCOG equivalent to Indian MD degree? MRCOG is more than an Indian MD degree, unfortunately, because MRCOG is an international degree. So our Indian MD degree may not be recognized outside India, but MRCOG has worldwide recognition. There are no more questions, so I think we can end this presentation. So thank you all for listening to this session. And in case anybody has any query, we have given the contact details which are coming on the slide. Please contact us there. You can email us, you can WhatsApp us, you can telephone us. And thank you so much for sharing your valuable time with us. Thank you so much.